Great. So these are my disclosures. So I thought we'd start with why do we write clinical practice guidelines? So as Annette said, in the UK, we've just spent the last conservative estimate is 3 years revising our pregnancy and postpartum guidelines for women living with HIV. So why do we spend our time doing that? So the main aim of the guidelines is to improve the quality of care and to provide a synthesis of the currently available evidence, and to do that in a kind of robust way. So in the UK, we use the grade system to evaluate the research that we're putting into our guidelines. And the other thing that guidelines do is they give you a way to achieve consistency. So, for example, in the UK, we are interested in the experiences of women who are maybe having their babies at hospitals that have less experience of looking after women with HIV. So a guideline is written not just for the people like us that come to HIV conferences, but also for the people that don't and who have less experience and maybe less confidence. And one of the key focuses of guidelines should be to empower and centre people with lived experience, and I'll talk a bit more about that later. Guidelines can also influence public policy, and they should always be driving benchmarking and the evaluation of clinical services. So I'm going to talk about 4 things that I think that we had a lot of debate about in our guidelines writing group, the things that were maybe more controversial. So I'm going to talk about what we do with people who decline HIV testing in pregnancy. I'm going to talk a little bit about novel ART strategies in pregnancy, about infant postnatal prophylaxis, and of course about infant feeding. And there's a content warning, which is that I am completely focused on high resource settings here, and there will be a very strong UK bias. So let's talk about women or people who decline HIV screening in pregnancy. So in terms of what's happening with antenatal screening in Europe, in 2016, the ECDC published a report showing that not all countries had implemented antenatal HIV testing, and that only a minority were achieving the target of more than 95% coverage, which was set by the WHO. But since then, very significant progress has been made in Europe, with even very high prevalence countries achieving testing rates over 99%, although of course the Ukraine data is pre-war data. And the impact of screening programs has been noted in several countries, for example, the UK and Germany, to have then contributed to extremely low transmission rates in those countries. So in the US, the CDC also recommends opt-out testing in pregnancy, although there is some evidence that there are some studies showing that when asked about whether they were offered testing in pregnancy, less than 80% of people said that they were. So it looks like there's room for improvement, although that data is a few years old now. And this was a surprise to me when I was researching for this talk, that mandatory newborn screening has been adopted in several states in the US. In some areas, the mandatory screening is for all newborns, and in some areas, it's just for newborns born to people who've declined HIV screening in pregnancy. So what do we know about people who decline HIV screening in pregnancy? So we know that some people, or women or people, I'm using both terms to be inclusive, are experiencing needle phobia, and therefore it's a problem with having a blood test rather than the HIV test itself. And all maternity units should have a policy to be able to deal with this. Some women and people want to decline all interventions in pregnancy because of their health beliefs. Some people don't feel that they're at risk of HIV, or perhaps that's what they're telling other people. Some people, and I've had patients like this myself, don't feel able to deal with a positive result, and some are worried about confidentiality, and obviously some people are worried about some of these things at the same time. We know very little about whether people who decline HIV testing in pregnancy are at higher risk of having HIV infection. There's almost no data on this at all. There was a very small single centre project reported from Manchester in England, where they looked at reasons and outcomes in people who had declined HIV testing and screening in pregnancy. And out of 6 women who declined because they felt like they didn't need an HIV test, 2 of them subsequently went on to test positive. And I'm sure we all have anecdotal stories like that. So the situation in the UK is that universal antenatal screening, which is voluntary and opt-out, was introduced in the early noughties and is now, as Rebecca said before the break, recommended alongside hepatitis B and syphilis screening at the antenatal booking appointment in the first trimester. And since 2011, we've had very high uptake rates above 97%. And as Rebecca alluded to, the standards for the screening programme are set by a group that currently works within NHS England, although of course that's now been abolished, who are the Infectious Diseases in Pregnancy Screening Programme. And they write the standards for the screening programme, and then ISOS are collecting the outcome data for that screening programme. So for women and people who decline the first offer at the booking antenatal appointment, the guidelines from the screening programme then recommend that they are formally re-offered a test at 20 weeks. And this coincides with the schedule in the UK of having an anomaly scan. So that's often an opportunity, if there haven't been one before, for the antenatal screening team to get a face-to-face meeting. The discussion should be respectful and not coercive, and should attempt to identify any risk factors. And then women or people who then decline that re-offer should then be referred to a paediatric infectious diseases MDT. So with the BEVA guidelines, which are mostly aimed at managing HIV in pregnancy and the postpartum period, we wanted to provide some additional guidance to these MDTs about what they should then do. And this was a big point of debate within our team, which is very big. And the debate comes from that tension between trying to preserve women's autonomy and the fact that this is an opt-out testing programme, screening programme. This is not mandatory testing, and that's a core principle of the programme. And balancing that with the rights of the infant from being protected against HIV, taking into account that if you do serology on the infant, that is going to reveal the maternal HIV status. So it makes it a very complicated thing to work out. So we reached a consensus that we would then recommend infant testing to the birthing parent or mother of that infant if there was no HIV testing in the pregnancy, and that should be done by the paediatric team at the time of birth. That we would emphasise a supportive approach with a continuing dialogue, that we would make sure that the infant's GP was informed, and that the parents would be followed up by a sexual health advisor for potential testing in the postnatal period. Okay, so moving on to novel ART strategies. So this is just a reminder about the things that we consider when we're evaluating antiretroviral therapy in pregnancy. So of course, we want to make sure that drugs are going to reach the right levels with the body going through the profound changes it does in pregnancy. We want to know whether drugs are going to be transferred via the placenta for additional protection of the fetus. We want to know that the drugs are safe to take in pregnancy. We want to look at outcomes such as low birth weight and preterm birth. We want to make sure that the drugs work in terms of suppressing virus in pregnancy and at delivery. We want to make sure they're safe to conceive on. And we want to know whether exposure in utero and through breastfeeding is going to affect infant growth and development. But of course, we don't always have the data, and this is a brilliant illustration of the time it has historically taken from a drug being approved for use in the UK, in the world adult population, to how many years it takes to get any PK data in pregnancy, and efavirenz wins with a gap of 12 years. But this is thankfully now changing because it's a global priority to get this data in pregnancy, and we are, obviously now seeing lots more studies geared towards people who can get pregnant. So the first strategy we're going to look at is dolutegravir lamivudine in pregnancy, so dual therapy. And I guess the first important thing to think about is what is happening to the PK of dolutegravir in pregnancy. So the first thing to note is that dolutegravir is very highly protein bound. So when you're doing PK studies, it's really important to look not just at the protein bound component. You need to look at the free fraction as well, because these serum proteins decrease as the pregnancy progresses. So the IMPACT study team did find that dolutegravir exposure in pregnancy was lower compared to the same women in the postpartum period, but the median area under the curve in pregnancy was similar to non-pregnant adults, and trough concentrations were much higher than the dolutegravir EC90. And similarly, the dolphin study group did also find reduced dolutegravir exposure in the 3rd trimester compared to non-pregnant adults. However, nearly all of the dolutegravir concentrations were above the protein-adjusted IC90. That's why it's really important to adjust for the protein levels in the serum. And the PANA group looked at free dolutegravir concentrations and found that they were similar in pregnancy and postpartum. So the conclusion of all of that work is that we don't need to dose adjust dolutegravir in pregnancy unless there are significant drug-drug interactions. And both IMPACT and DOLPHIN demonstrated that dolutegravir does readily cross the placenta, providing additional protection to the fetus and the neonate. But we have very, very little clinical data on using dolutegravir lamivudine in pregnancy. So to date, and I hope this is still accurate today, it was a couple of weeks ago, there have only been 32 published cases of the use of dolutegravir lamivudine in pregnancy. There was a small pilot study published in Brazil with only 20 women who all initiated dolutegravir lamivudine in pregnancy. They had a mean baseline viral load of around 10,000, although it was quite a wide range. Mean time to suppression was 40 days, and all women were suppressed at delivery, and there were no perinatal transmissions. There were a further 11 cases retrospectively reported from Italy, and 10 women had a viral load less than 20 copies per ml at delivery, and 1 had a viral load that was just above the limit of detection. And there's been 1 other case reported from Berlin. So, moving on to long-acting cabotegravir rilpivirine, which is obviously an incredibly hot topic at the moment. So the PK data that we have on long-acting cabotegravir in pregnancy comes from the HPTN 084 study, where they obviously used a long-acting cabotegravir 8 weekly for PrEP in people without HIV. And they enrolled women and people who could get pregnant in an open label extension sub-study where they were unblinded and they were able to come off contraception, and if they became pregnant, they were allowed to stay on the long-acting cabotegravir if that's what they wanted to do. So among these 3 groups, those who were exposed to long-acting cab in pregnancy, those who were exposed prior to pregnancy but then stopped, or people who were not exposed at all, there was no difference in terms of pregnancy-related AEs. There were no maternal deaths. There was 1 major congenital abnormality in the long-acting cabotegravir exposure during pregnancy group. And the same study then looked at PK of long-acting cabotegravir in 50 women during pregnancy, and they did find that trough concentrations of long-acting cab decreased from the first through to the 3rd trimester. However, the trough concentrations were in the most part higher than the target for the study, which was 4 times the protein-adjusted IC90. So that was 100% of participants in trimester 1 and trimester 2 were above target, and 98% of participants in trimester 3. So this is the only PK, but it's fairly reassuring PK data for long-acting cabotegravir in pregnancy when used as PrEP. And then again, we have very, very little clinical data on the use of cab rilpivirine in pregnancy as treatment. This poster was just presented at CROI 2 weeks ago. This is a US retrospective multi-center case series of just 23 women who received long-acting cab rilpivirine in pregnancy. It was a very mixed group, so 17 of these women had been initiated on long-acting cab rilpivirine prior to the pregnancy, and some of those women continued it in pregnancy, but some of those women were switched to orals, and then 6 women were initiated during pregnancy. And the take-home message is that of this very heterogeneous group, 80% were suppressed at delivery, and 95% were suppressed to less than 200 at delivery, but that does include those small number of women that were switched to oral therapy during the pregnancy. And we know that now Impact 2040 is recruiting 45 women to explore this in a much more robust way. So they'll be looking at PK and safety in these women, and also looking at different dosing schedules, because, I mean, in this case series, there was a mixture of women receiving the long-acting cab rilpivirine, some receiving it in 4-weekly dosing and some receiving it 8-weekly dosing. Okay, so I mean, our consensus in the guidelines writing group is for the dual therapies is that we don't have enough evidence to recommend them, and we do recommend intensifying to a 3-drug regimen because we have so much more data for that. But in the situation where a woman really, really wanted to continue her dual therapy, or there was some very good clinical reason, then that should be referred for an MTD decision. So that's really a kind of a patient-centered decision-making process. So I'm going to move on to infant postnatal prophylaxis. So this is a survey of both policies for postnatal prophylaxis and infant feeding policies that was conducted by the Penta study group. They collected this information from experts across Europe in 2023. And in terms of the results for the postnatal prophylaxis, they did find a very wide variation in practice. So you can see from the first table up here that some countries have adopted a no postnatal prophylaxis policy for the lowest risk infants. Some are giving 2 weeks, some are giving 4 weeks, and most people were giving zidovudine monotherapy. There were a small number of countries that are giving nevirapine. And there was also a mixture of countries having policies where they had 2 risk categories and countries where they had 3 risk categories for these infants. So what is the evidence for postnatal prophylaxis in those lowest risk infants? Well, the original evidence for zidovudine monotherapy came from the ACTG 076 study, which gave 6 weeks of zidovudine monotherapy to infants. This is obviously in the pre-CAR era. And again, in the pre-CAR era, there was another randomized controlled trial in Thailand, which compared short and long PNP regimens and found that there was no difference in transmission rates in women who started ART by 28 weeks. And then fast forwarding to the current treatment era in Germany, they've been using 2 weeks of zidovudine monotherapy for more than 10 years now with no signal of increased risk of transmission. And they've also shown that there is lower risk of hematological toxicity in the infants. And some countries, for example, Switzerland, have now extrapolated U=U data and have adopted a no PNP policy for the very lowest risk infants. We know from French data that there were no cases of vertical transmission in 5,500 women who were on combined antiretroviral therapy at conception, continued it through pregnancy, and were undetectable at 36 weeks and at delivery. So in those optimal scenarios, the transmission risk is extremely low. However, there are still vertical transmissions that happen in women who start ART in pregnancy despite having an undetectable viral load at delivery. So in the UK, we are, in our new guidelines, which are just about to come out, we're moving from 3 risk groups to 2 risk groups, and we are categorising the lowest risk group as infants who've been born to women who had more than 10 weeks of ART in pregnancy and who have been undetectable for 10 weeks or more, with room for an individual risk assessment if the viral load is between 50 and 200. So finally, probably the hottest topic in the talk, it's infant feeding. So this is, I hope it projects okay, a very, very beautiful timeline that was presented at IAS 2023, showing the milestones in prevention of vertical transmission over the years, and just highlighting, obviously, that breastfeeding was first regarded as a mode of HIV transmission in 1985. WHO first guidelines for exclusive breastfeeding in certain settings came out in 2010. The PROMISE trial data came out in 2018, and of course then in 2023 the US announced that they were adopting breastfeeding options into their guidelines, and the Swiss also reported on the successful implementation of their guidelines. But I'm sad to say there is one very important milestone that is missing from this timeline, and that is that in the UK we've been supporting women to breastfeed since 2012. So what do we know about the risk of vertical transmission in women who are on effective antiretroviral therapy? So obviously 2 big important studies that looked at this, the IMPACT PROMISE trial, which recruited from multiple sites in Africa and India and compared women-infant pairs where the infant was on extended postnatal prophylaxis with nevirapine, and an arm where the women were continued on effective antiretroviral therapy through the postpartum, the breastfeeding period. And in that maternal ART arm, the transmission risk was 0.3% at 6 months and 0.6% at 12 months. Now, most of those transmissions happened when the woman was detectable at the time of the transmission, but there were 2 transmissions that happened where women's viral load was undetectable at the time of transmission. And then in the Dolphin 2 study, which compared dolutegravir and efavirenz, started late in pregnancy and then continued through the breastfeeding period, there was 1 linked transmission in the efavirenz arm, and this transmission happened at 72 weeks, where the mother had been undetectable at all the time points prior to that 72-week transmission, and the infant had been negative up until that point as well. So the situation in the UK is that among 8,500 live births, around 200 women were supported to breastfeed between 2012 and 2021. And as Rebecca said, they are about to publish a new report which will have very much more up-to-date data looking at the subsequent years. And I can tell you unofficially that numbers have gone up even further. Commonly reported reasons for wanting to breastfeed were bonding, the health benefits of breastfeeding, disclosure concerns, previous experience of breastfeeding, and maybe pressure or expectations from family and friends. And to date, there's been no cases of transmission in women who've been supported to breastfeed in the UK. So I'll just quickly signpost this, which is that the Penta survey also looked at the variation in practice in infant feeding guidelines across Europe. And as you can imagine, there is wide variation in practice. And in 2023, when this survey was done, only 8 countries were currently allowing or supporting breastfeeding in HIV. So we have subtly changed our language, and Shima, who is in charge of the breastfeeding section of the guidelines, is going to come up to the panel for the discussion a bit later. And we have changed our language so that we are no longer saying that formula feeding is the best way for someone to feed their infant. We are saying that there is still a small risk of transmission with exclusive breastfeeding, and if someone wants 0 risk of transmission in the postpartum period, then they should choose formula feeding. However, if they want to breastfeed and they fulfill our criteria, we will then support them to do that. We have been doing this, though, since 2012, so that is not new. So lastly, I just wanted to signpost you to some amazing resources that have been developed in the UK. There is the Nourish study group, which is based at the University of Oxford, which both Shima and Angelina are involved with, and they have developed some really amazing videos, which are on the HEXI website, which are lots of experiences of women talking about making infant feeding decisions for their infants and their experiences of different types of feeding. And the 4M Mentor Mother Network has also produced a great leaflet for women who are thinking about becoming pregnant. And finally, our BEVA Guidelines writing group have written some patient information leaflets on infant feeding, so that's also available at our BEVA website. So in conclusion, there continue to be large evidence gaps due to historical lack of clinical trials which have included women or people who can become pregnant. The situation is improving due to global efforts to protect pregnant women or people through rather than from research. Observational data from high-resource settings can fill some of these evidence gaps, but this requires international collaboration, which is perhaps becoming more difficult this year. There remains wide variation in practice, and this does reinforce inequality. It's essential that clinical guidelines are co-produced with people with lived experience, and that community engagement is extensive and meaningful. Thank you very much.